It's 1:45 and I think we should start promptly. So, welcome everybody to the Elwick Centre. It's really nice to see so many people. We will attempt to get as many people in the room as possible, even the latecomers, so thank you all for coming. My name's Lorraine Denoris, and my job this morning is to provide the discussion that you're going to have with some independent facilitation. I don't work for the NHS, I'm not an NHS employee. I am here because I am going to help you express your views around some of the very important issues that we're about to discuss, around how your services in East Kent may be provided going forward. I do live in East Kent, so I'm really very interested in some of the issues and some of the discussions that you're going to have, because like most of you in the room, I'm a patient and I care a lot about how health and care services are planned and delivered in the area. So it's really good to see so many people here. There are some people in the room who will be providing you with information. The one thing that I've learnt as I've been trying to get my head into some of the issues that you're going to discuss is that it's not only really complicated, but it's quite complex. Some of you will have seen press coverage about some of the things that are being proposed, and you'll have seen lots of articles and lots of things on the internet and all of that. What I would ask you to do is just listen to some of the things that colleagues are going to tell you before jumping to conclusions, because at the end of the day, I'm fairly convinced, well I am convinced, that decisions haven't been made yet. We haven't even moved into public consultation. What we're doing here is sharing with you where we've got to in terms of the current thinking. Does that make sense? So, I want to introduce to you a couple of people who will be providing you with information about some of the plans. Could the speakers please stand up for me? Okay. So we've got 4 speakers in the room representing parts of the system. I'm going to start over there in the corner with Matt. Matt, would you introduce yourself?
Hi, good morning everybody. Good morning everybody. I'm Matt Jones, Dr. Jones. I'm a consultant anaesthetist. I work in East Kent hospitals across East Kent.
Caroline at the back.
Good morning everybody. My name is Caroline Selkirk. I am the Managing Director of the 4 clinical counselling groups in East Kent.
Okay. Liz?
Hi, I'm Liz Shotler. I'm the Deputy Chief Exec of East Kent Hospitals.
Thank you. And lastly, Navin.
Good morning everyone. I'm Navin Gupta. I'm a GP and I work at Willsborough Health Centre in Ashford.
Okay. So these folk that have just introduced themselves will be giving you some information during the course of the morning. There are also some other people in the room. There is Paul Bentley, who's there. Paul is the Chief Exec of the Community Trust. It's really important that they're involved in these discussions, and we've got representatives from KCC and the Mental Health Trust as well in the room, who will also be here to listen to the conversations, listen to the feedback and take part in the dialogue. So everybody's welcome. There's a number of other clinicians in the room and you'll get to know them as we go through the discussions. So,
where's the agenda for the morning?
The agenda will come. I'm just about to go through the agenda now. So, on that point, thank you for raising it. We have constructed the agenda very specifically. We know that in order for you to have the conversations we want you to have and to give us the feedback we want, you'll need to hear some stuff. And you're about to hear some stuff from those speakers. We're then going to give you an opportunity to ask questions. And we also know that some people in the room may not want to talk in the full session, so we're going to give you an opportunity to talk in tables for probably about 20 minutes or so. And some people will prefer to talk on small tables and make notes and give us written questions, so that when we come to the final plenary session, and we will give you lots of time to ask questions of the people who are presenting the information to you, we will be able to manage that process. So it'll be a bit of both. We'll take it as we find it. We'll be flexible in terms of the agenda, but we want to give as many people an opportunity to talk and give us feedback as possible. So, as I said, the one thing that I do want to emphasise is at this point in time, what the folk are doing here is testing emerging thinking and ideas. Okay? So it's really important that we understand that this is just about a pre-consultation engagement, getting people's understanding, getting people's views on the current thinking. The opportunity to feedback is really important because some of the things that you say, and we've got some questions that we'd like you to give us some specific feedback on, will inform the way in which we construct our future consultation should we get to that point. I'd like to suggest some ground rules, please. I would like to suggest that, if possible, folk would turn their mobile phones off, to vibrate at least, if possible. Some of you may well want to take videos or pictures. I've spoken to the speakers who are very happy for you to so do, but there may be people in the room who don't want you to video or take pictures of them. If you don't want pictures taken of you, please could you indicate to one of the speakers, myself, or a table facilitator who will introduce themselves shortly. But if you are taking videos, could I ask that you respect people's personal body space as well? If you're taking recordings, please can you also let us know that you're so doing. Is there anybody in the room who's wanting to record or take videos? Thank you.
Audio record.
Thank you. Okay, we've got an audio record in the room. Thank you. Okay. Other ground rules then, please. Lots of people with lots of different views. Please can I ask that you respect them even if you don't agree with them? And please can I ask that you don't shout over people? I'm going to be handing out a mic with my colleague Linda. We want to be using the mic because there are people in the room who want to make use of the loop system. So please can I ask that you speak into the mic. I'm going to ask people to be as succinct as possible, although people will have obviously a lot of things to say. And I want to just remind you finally that everybody, I suspect, in the room is here because they care about the NHS and social care. And I think it's really important that as we have these discussions, and there may be different opinions, that we remember that everybody is here because they care, and everybody is here because they want to see best possible development of services in East Kent. So on that note, have I forgotten anything? Fire and toilets, just in case people need the facilities. If you haven't discovered them already, the toilets are downstairs by the entrance. We are not expecting a fire drill, so if it goes off, it is real. There are 2 exits. There's one here in the corner, and there's one at the end of the room by the entrance. Can I ask you to try and keep it clear for me, please? The muster point is just on the corner here by the side of the library, so please could you exit by one of those routes and meet by the library. Have I missed anything?
Yeah, apologies. The Elwick Club have very kindly put the heating on full. Would anybody mind if it was turned down a bit because it's going to get quite warm in
It
here?
is a bit hot.
Anybody
isn't
mind?
it? Anybody mind turning it down? Okay, we will get that.
I've got the thermostats, the Drayton ones on me.
Okay, going back to your agenda point. Here are broadly the issues and the structure of the discussions. We're going to outline the opportunities. We're going to summarise how services outside the acute hospitals will be developed to maximise care. We're going to explain the options in some detail to you. We're going to give you an opportunity, as I said, on tables and in full plenary to make your points and give us some feedbacks. And in so doing, we're going to test out our emerging thinking. And we're going to finish on time. So, on that basis, my friends, are we prepared to continue with the meeting? Yep. Good. I'm going to invite Caroline Selkirk then to please kick off for me. I am going to do the video first, sorry. Before I invite Caroline to kick off for me, I'm going to share with you a very short 3-minute video.
Sometimes, you know, if you really wanted to speak to the doctor that you've gone through from the start, I wonder if that will carry on.
If you want a normal appointment, you cannot wait up to 2 weeks. I mean, if you're going to be ill, you just have to sort of book in advance to be ill, if that makes sense.
People like me are getting older, so we're obviously going to need the A&E.
If it's not an emergency, don't overburden your A&E department.
It's the waiting.
Yeah, the waiting is crazy.
If you had somebody you could consult, you probably wouldn't need to keep going to A&E.
Well, everyone's paid into it. Everyone should get care when they need it.
Stay in your home, obviously one would prefer to stay in a home, than have to go into hospital.
Put more money into the recruiting, I think.
I think organisation and funding is definitely the key here to be able to help out.
Medicine has changed massively since I've been a GP for the last 20 years. It's changed from people having quite straightforward problems to much more complicated, complex problems such as diabetes, asthma, COPD, numerous problems that mean that we have to spend longer with our patients. East Kent's a very large area and quite a lot of it's rural, and so travelling times can sometimes be quite long for people to go to hospital for something that would often seem quite straightforward. So what we're trying to do over the next few years is to structure our healthcare and care system in a way that means people don't have to travel unless they absolutely need to from their local area. We want to work with patients to find solutions to modernise our healthcare service to provide 7 days a week high quality care.
I deal with operations or patients who have had injuries to the face, including hard tissue and soft tissue, but also deal with people who have cancers of the mouth and face. Quite a lot of specialist services are already centralised in East Kent. The head and neck cancer service is centralised at the William Harvey Hospital, vascular surgery is centralised, urology services are centralised, and complex heart attack services are centralised as well. We can't have these services in every hospital because these are very specialist teams comprising of surgeons, theatre teams, ward nurses and therapists. But the specialist centre is still in East Kent, it's not travelling to London.
The emergency department is all about saving lives. We see the sickest patients first, and those with who are less unwell will need to wait. To be honest, they're better off being treated elsewhere within the local NHS, such as their GPs and urgent treatment centres, and that enables us within the emergency department to deliver the highest quality care to the critically unwell. The saving lives is our main priority.
When I started, we didn't have a frailty team, so we are now the community frailty team who work across Canterbury and Ashford, and we look after people in hospitals, in the community hospitals. We look after people in their own homes, and we do quite a lot of work in care homes as well. At the moment, we invest a lot of money in our hospitals, and people are in those hospitals for much longer than they should be for various reasons. It's just we have developed a system which means people stay for a very long time, a lot of the time. And people don't get better in hospital often, they often get worse, particularly in the context of dementia, because people with dementia will often get much, much worse. It's very frightening to be in hospital.
I tend to see really complex patients who have high needs in terms of frailty, and within that we see a number of patients who have long-term conditions, including dementia. The right thing to do is to get you home, because all you're going to get by being in hospital is more muscle wasting and the risk of more infections, and actually the loss of your independence.
What I think is necessary is that we invest in our community services to allow people with frailty to stay at home and not be endlessly in and out of hospital.
We understand that change can be worrying. What we're trying to do here is to enable patients, as many patients as possible, to be seen as locally as possible.
If the case for change allows for more people to be at home and good, proper care being provided for them at home, then that would be the outcome that I would want.
It's really important that we understand the patient's viewpoint in all of these changes we're trying to make, because ultimately that's what it's about.
Okay, now I'm going to ask Caroline to come up. Thank you.
So thank you very much. Oh. Thank you very much.
I think it's with my right thing.
Right, okay. Right. So thank you very much, and thank you for coming along. So today what we're going to talk about is we're not just going to talk about hospital services, we're going to talk about the whole of your care. And that's really important because we've started making and we're continuing to make lots of changes to the way in which services are provided locally in your community. And that affects not only what happens locally, but also what people previously used to have to travel to hospital for and now don't need to. So we know that 90% of your care is already provided in out of hospitals. It's provided in your GP surgery, in your local pharmacist, it's provided in a whole range of settings outside the hospital. And only 10% of care is provided in hospital. So that is your very specialist services, as we mentioned in the film, people who have complex needs that mean they're admitted to hospital, and also people who go to hospital for routine outpatients and procedures. So even in that 10% of your care that you get at the hospital, more and more of those outpatients can actually be provided locally. And we'll come on to talk a little bit about some of the exciting things that we're starting to do more locally in your community, which save you having to go to hospital. So in this first section, our plan is to spend some time talking about what we're doing in local care, and that's a kind of introduction to us then talking about how does that affect the hospital services and what we're planning to provide within hospital. Am I shifting this? Okay, we did it right, okay. So today is very much about hearing your views and how your views can influence where we are. This is an engagement event. We're going to talk about two options, and we're going to describe to you what those mean. And you asked us to do that in quite a bit of detail. So later on, in this morning, we're going to spend time telling you a lot of detail about what is described. So we're going to set out this morning, why is it we think we need to change? We really want you to tell us, what do you like about what it is that we've said and across all the proposals, not just the hospital, in terms of what we're doing in local care, what we're doing with our social care colleagues. What are the things you're really worried about? What are your concerns? Are there any things you like about what we're doing currently that you want us to do more about? Is there anything you really don't like that we're doing at the moment that we need to look at better? And you'll see on your tables that we've got a little leaflet which talks about you said, we did, and that shows you some of the changes that we've already started to make. So what I want to do now is to introduce the country chair of Ashford CCG and who can talk about, so Dr Navin Gupta is going to talk to you about what it is we're doing in local care and why we have to make some of those changes.
Thank you everyone for coming here really, and thank you Caroline. I think I've been a GP, I'm Dr Navin Gupta, I'm a GP at Willsborough Health Centre, as I mentioned earlier, which is about 20 minutes down the road walking distance. I've been in Willsborough Health Centre since 2005, and I also trained at Willsborough Health Centre as a GP, having spent time in the East, at the hospital. So I've been at East Kent Health System for the last 15 to 19 years. And I'm hoping that what I can provide you now is the vision that of a better care for the population of East Kent, for the population of Ashford, so that we can improve the care that is there from the current and build on it. The vision is about better prevention. The vision is about more local and comprehensive care, which is more local to people. The vision is about an urgent care which is comprehensive and a 7-day service, and about specialist care, which is also specialized, centralized, and available on a regular basis to those people who need those specialist care. But also we need to remember about the workforce and the recruitment, which has been mentioned in the film that came through. So that's the plan really. We need to start with the challenges. The challenges we face are mentioned up here. I think a lot of people have read about these challenges, but they are real challenges on a day-to-day basis. 1 in 4 emergency hospitals can be prevented. There are about 300 people who are in the hospital at any given time who don't need to be in that hospital environment. Yes, they still need the care. Yes, they still need the health input, but they don't need to be in the hospital environment. In fact, being in the hospital environment, as was mentioned in the film, actually does not help that particular person. We know that every day spent in the hospital reduces the muscle mass by about 10%. So we need to make sure that those people who are in hospital beds are those people who actually need the hospital beds, and therefore there is a system around the hospital in the community that prevents people from being in the beds for longer than they need. Specialist hospital teams cannot run a full service 7 days a week. That's one of the challenges. Waiting long in A&E. We have all read about it. It's a national issue. It's also very local and a very live issue. GP practices, smaller GP practices are unable to offer all the services. That's a challenge moving forward. If we have a system that works around patients more locally, we need to ensure that local services and practices are able to cope with that. And the challenges of recruitment. Consultants, GPs, nurses, therapists, social workers, the list goes on. It's an issue that is about recruitment and workforce. I started in medicine in 1997. That was a long time ago. And I think things have definitely changed. A lot of things, I believe, have changed for the better. Things like warfarin checks, they don't all have to be done in the hospital anymore. They can be done in general practice. People who have hemophilia, which is a blood disorder, they don't have to go to the hospital every time for a check. They can have their assessment at home and send those images and that assessment for the hospital and people to assess them and give them the reassurance that is required. We have a surgery, a new Hayesbank surgery in Ashford, which also runs an eye clinic. They do surgery, eye surgery in a GP setting. In 1997, if somebody asked me is that possible, I would have said that's impossible, especially when I was working in A&E. I used to admit all patients into the hospital at that time for eye problems, absolutely. And I still think some of the eye consultants are still probably remember my name for all those referrals that I keep on sending, which didn't need to be sent in. Robotic surgery, this is the specialist field. Specialist field about robotic surgery is improving. It improves the outcome in prostate cancer and it is beneficial to our patients. The benefits, what we're looking for is, as I mentioned earlier, is the local care. The wide range of services, GP-led teams able to be delivered locally to people and coming together of general practices so that it doesn't matter whether you're a small practice or a big practice. It's about delivering that service to that population and that population together as a family of GP and a family of GP practices together. Urgent care, better urgent care locally, and improved access. The film also mentioned about access and waiting time. Improved access to general practice is very important. In terms of hospital care, the list is about specialist services, centers of excellence, and offering the treatment that is appropriate, right, and the right time. And planned operations that go smoothly, that go effectively, and patients don't stay in the hospital longer than they need to. What does that mean locally in terms of what are we doing in that sense in terms of the local care? We already have general practices that are working together. There's a federation of GPs that are working together who are happy to see patients from another surgery. For example, if somebody needs an ear problem, at Willsborough Health Centre we don't have an ear clinic, but there is Selin surgery, Y surgery, who I can refer my patients to. That wasn't happening about 5-10 years ago, so we're working together in that field. Improved access. There is an improved access, which means weekdays from 6:30 in the evening to 8 p.m, Saturdays and Sundays, the population of Ashford can access primary care services in general practice setting. That started from the 1st of October, and we are aware that 100% of the population can access it. It may not be your specific surgery that's open, but it will be a surgery that is close to you that you can access to and get the help from, and we are happy to work across surgeries. I mentioned about the wide range of services. I mentioned about the eye clinic. We also have things like skin triage systems. When we look at through a specific camera in a skin lesion, send off a photograph to a skin specialist, get an answer within 48 hours, thereby reducing the waiting time. Care homes and frailty, that's another big thing that's going on. We have, from the community trust, we have consultants who are specialists in the field of elderly care medicine, who are helping general practice, who are in turn helping the voluntary sector, and we have an urban multidisciplinary team, a team of people who come together to say what can be done best to deliver care for somebody who is frail, local to home, rather than having to send them into the hospital. I think the plan is to build on this and strengthen these proposals over a period of time.
Okay, thank you, Mavin. So,
just to try and summarise what I think you're saying, your proposition is that by extending hours and access to appointments in primary care, by working differently in teams of different specialists, and by using modern technology, you are able to keep people out of hospital. Have I understood that correctly?
Absolutely.
Okay.
Absolutely.
Anybody got any comments or questions on what you've heard so far from either Caroline or from Navin? Yes, sir. Would you mind just introducing yourself?
My name is John Fletcher. I'm the Governor of the Community Services Trust and I represent the Ashford area. I was interested in what you say. You were suggesting...
Just stop for one moment. Martin, could you turn the mic up for me? Cheers. Would you mind starting again, please? Sorry.
Yeah, sorry. Is that
That's
better? Yeah, sorry. Okay. My name is John Fletcher. I'm the Governor of the Community Services Trust and I represent the Ashford area. I was interested in what you said in relation to the relationship between doctors and patients, because I suppose if you go back far enough, the relationship of a patient and a doctor was very much a personal one. The doctor knew everything about the patient, and always the patient saw the same doctor. Now it seems to me that in order to have efficiency of use of resources, you can't do that anymore. And is that what you're saying, really, that sort of relationship of doctor and patient will no longer exist, because patients will see a team, not necessarily in their own surgeries, but probably anywhere within the group that the surgery belongs to?
Thank you, John. I think that's a very important question. I think it's not, the answer is not yes and no, because things have changed. Medicine has changed, as is the conditions. People live longer. Dementia, about 50 years ago, that dementia was not a known diagnosis. A lot of infections were actually not treatable. Cancer was meant death, basically, effectively. So effectively, the improvements in medicine have meant that it has been more effective for medicine to help people. People live longer with a lot of more complex problems as well. And therefore, I would challenge whether the patient-doctor relationship in today's medicine, in today's problems, is absolutely needed for every single person. Yes, it is important, but it may not be necessary for every single. And I think that's very useful when I go to the urban, I actually am one GP who attend the multidisciplinary team meetings. And I go there because sometimes I cannot help that particular frail person, or my colleague who is another doctor can't help that frail person. And there is Age UK there, there's a community trust there, there's Crossroads there, who are able to provide that other help that is required. Because it's not about that medical aspect of things, it's about the other frailty aspect or the complex need aspect that is more important to that patient. So the answer to your question is yes, it is important to have the one-to-one relationship, but it's also important for a team to know the person, because if you don't know the person, you won't be able to deliver care in a good team setting, really.
And we're still going to have the one-to-one. And we will still have the one-to-one, even if at a reduced level, will we?
The aim is to maintain that, even if it's at a reduced level, absolutely. But the hope is, once you have the other people in there, you may not need the general practice, because then the general practice can look after the more complex needs. Because it's all about making sure that there is scope for any particular aspect, and the team to work together, really. I know of people who have to, I go in and say to them, doctor, you're the 5th person to come in today, and I don't know who the first 3 were. And that's so confusing to them. They're anxious, they don't know what's happened. And that needs to change. It needs to be more streamlined. So you need to have people who know the person as a team rather than just that one person, because all of them are helping that particular individual.
Okay, any other comments or questions? Yes, there's a lady here with glasses. Hello.
Hello. Oh, sorry.
What's your name?
I'm Sandra. I'm from Folkestone. I think that what you're proposing sounds great, really, except in Folkestone we've recently had several GP surgeries shutting because we can't recruit GPs, so I can't, in that sense, maybe you're going to come on to recruitment later, but if you're talking about people working together, our GPs are already massively overburdened, so that concerns me that you're then going to I mean, I think it sounds better to keep them out of hospital, but we already can't cope with what we're doing.
Yeah.
So is there some solving of that?
Sandra, it's a point that has been made to us on a couple of occasions, and it's a good point. So, yeah, let's pick it up. Caroline.
Thank you. So I'll answer the question about in relation to Folkestone, but it actually applies everywhere. So I don't think it's so the first thing is there's no point in pretending that we can clone the GPs we've got and somehow make that problem go away. We're not going to be able to do that. So we have to think about how we provide services in a different way. Now in Folkestone, and this is also happening in Ashford, but in Folkestone specifically, the GPs have now, and I've actually been to several meetings in the last couple of months, have started thinking about we can't all just work on our own, we're going to have to work together. And so those GPs are starting to think about how they provide services, just in the way that was described earlier by Dr. Kupta, about how do they provide services to people across a number of surgeries. And that's the only reasonable way in which we are going to be able to do things differently. So I've seen a real change in the way that people want to work together in Folkestone. I see that in Ashford as well. The practices all starting to think about how they work together. Now we've helped that because there are a number of systems that your GP has to record the information that they have about you, and the GPs in East Kent are all starting to use the same system, which is really good because it means that if you see a GP from another surgery, they're able to access your records, and that's a very helpful thing to be able to do. I think the other thing to say though is GPs are becoming, they need to see the more complex patients, and they need to see the patients where continuity of care is really, really important, and they need to provide a second opinion if you've seen somebody else and know that person needs to refer on. But there are a lot of things for whom somebody else might be better. So, people who might be younger people who have something wrong with them, have a rash or something, any doctor will do. And in actual fact, sometimes it's not a doctor. A pharmacist would actually be a better person. So we're trying to get to the stage where we get the right person to the right specialist, and in doing that, actually, that's the only way we're going to preserve continuity of care for those people who do need to see the GP because their care is more complex. But that's the answer in Folkestone, but it equally applies in the 3 hubs that are emerging in Ashford. And the really interesting thing is, it's not just about general practice. So our colleagues in the Community Trust are now working really closely with our colleagues in general practice. So you're starting to get that crossover across organisations.
I get it.
And I think that's really important.
I get it. Sandra, does that deal with your question? Yeah, thank you. Okay, any other questions? Yes, sir. I'm going to come here and here, and then I'm going to move on.
Hello.
What's your name?
Jonathan Dance. I have the good fortune to see many doctors frequently, so you can make of that what you will, in a personal capacity, not a professional one. Now, one of the things that's not been addressed, although it was very comprehensive, is the emerging body of evidence. If you check any database like PubMed or whatever, emerging body of evidence for the interplay between the patient's psychological well-being, even if they've got a physical condition, and the state of the physical condition. Now, the point made by the gentleman earlier in the front was the question of personal care. Now, there's an emerging body of evidence that the more personal the care is delivered, and of course it has to be good care, but the more the personal element can be brought in, the better the outcomes in many diseases, not all, but in many diseases for that particular patient. That's point one. And the second point, if I may, if you're having specialist GP services serving larger areas, for example in nose and throat, then you need to make sure that those specialist services are trained to the latest standards, so we're aware of the latest nice guidelines, and also that they have adequate time for CPD, because without CPD they won't be able to, continuing professional development, they won't be able to deliver adequate services. Thank you.
Thank you. Navin, do you want to comment, and then I'm going to ask Paul?
Yeah, no, thank you. I think that's a very important question. I think there are 2 points there. I'll take the second one first, which is about CPD and specialist training. You are absolutely right, and I think it's the specialist GPs are called as gypsies, which is GP with specialist interest, and they go through a regular sitting down with consultants. They have to have their professional development plan clear in place. When they have their appraisals, they are not only appraised on their general practice work, but they're also appraised on their specialist work as well. And in fact, the quality team in Ashford and Canterbury, since we've been as part of the CCG, have developed an appraisal and an assessment basis, a performance basis, which we ensure that these standards are met. And you're absolutely right. What is important is time is allocated to those specialists, not only to help develop but strengthen their craft so that they can deliver the most up-to-date treatment that is available in that specialism. And not only that, they also have a link with the team. For example, Dr. Timms, who is a cardiology consultant, the cardiology gypsy, has got help from a cardiology consultant and cardiology nurses to work together as a team. I've forgotten your first point.
I'm happy to repeat it. It's about the
psychology, yes. Very important point. I think one of the things I could talk about in the multidisciplinary team, we have Insight sitting with us, who are psychological therapists as well as primary care mental health workers. And I can give examples of a person who has got breathlessness because of their lung problem, and it's their anxiety that drove them into A&E rather than their lung problem. Utilizing the help of the psychological therapist and the primary care mental health workers meant there was a reduction in that person's attendance into A&E, which helped him and it helped his wife as well.
So Jonathan, what your question very helpfully does is highlight that actually it's not just one individual or one professional clinical group that will solve an individual's problem. So I'm going to ask Paul to comment on the community services very quickly, and also Helen to comment on the other point that you raised was around mental health and psychological support. So Paul.
I may slightly steal Mrs. Greatorex's thunder because my organisation, which is the Community Trust, and Helen's organisation, Helen Greatorex is the Chief Executive of KMPT, who's at the back.
Which is the Mental Health Trust?
Sorry, it's the Mental Health Trust. It's clear that there is an increasing crossover to the gentleman's question between physical health and mental health. And it's absolutely not apocryphal whereby staff who are, for example, a community nurse will be going up the garden path to a patient's home in the morning, and they will cross over with a community psychiatric nurse in the afternoon.
Right.
And it's one patient, and the patient's needs are physical and psychological. So what we're doing in conjunction with our fellow trust is to look at the crossover points, to train our nurses jointly so that they identify some of the systems and to collaborate much more effectively than we've ever done before. So it's a very good point, it's a very good observation, and it's something we're aware of.
Thank you. Helen, did you want to comment? Have you got a mic?
May I? Thanks, Lorraine. And I'm going to be really cheeky and walk down the front, so I don't like talking to people's backs. Morning, everyone. I'm Helen, I'm the Chief Executive of the Mental Health Trust, as Paul said. And Jonathan, you've just made my day because you've asked a question that is absolutely fundamental, which is what are we doing with this opportunity to really transform things in joining mental health and physical health together.
Is that on?
Should be.
You have to hold it
I'm
close.
a bit closer, is that better? Thank you very much. So Jonathan just made my day by asking that question, which is about what are we doing then? We know that if people are admitted to General Hospital for whatever condition, is it stopped now? I sound like Darth Vader. Closer to this, you think like that? Like this? We good? Like that? Really? Goodness. We know that if we're admitted to hospital and we've got no pre-existing mental health condition, our stay will be longer if our mood drops. Psychological interventions for everyone in General Hospital, whether you're going in for a hip replacement or some other form of surgery, can take days off the length of stay in hospital. So our vision is to have urology, radiology, ophthalmology, psychology, psychiatry on the same corridor. We should be properly joined up. We are whole people, and our mental health is as important as our physical health. So that is part of the transformation that all this work is looking to.
If it was that easy, why haven't you done it already, Helen?
Really good question. I think probably tradition. So organisations have been quite inward looking.
Right.
I've been in this job for 2.5 years, and when I came to Kent, ideal opportunity. Never before has there been so much integrated working. The fact that you've got all of us in the room this morning and we all know each other and trust each other and trust each other's teams who are experts. The clinicians are the experts in all this. What they need is the leaders of organisations to make it possible to do what's right for patients, and that's what's happening now.
Okay, that's helpful, thank you. I did see a hand here.
No, let's move on.
Let's move on, okay, and I'm going to take one more question then from you, so before we move on. Thank you, thanks Helen.
Good morning, my name is Edward Peel. I'm chair of MDS UK, which is a rare blood cancer. I've actually got MDS myself. one of the questions I wanted to ask was, with this joining up and spreading of knowledge, how is that going to help people with a rare disease like I have? Because I'm quite ill from time to time. My neutrophils are nil because of my blood condition. I've had sepsis a couple of times, and I've been into various hospitals, and when I go there, the lack of knowledge of MDS is astounding. It's very rare. It's one of the rarest blood cancers in the world. There's only a few hundred in the UK who have it at any time. Consequently, people and GPs don't know about it. Dr. Cocker was my own GP. When I was diagnosed, I was the first in 26 years to actually have it. What I'd like to know is, and we get this from all over the country, that people with this same condition go to their local hospitals and no one has a clue about it. And because of things like our neutrophils, we're put into general hospitals where people pick up diseases, etc., and that leads to sepsis and quick death. So how is this going to aid the spreading of knowledge of rare diseases?
Okay, it's a good challenge, and it seems to me like we need a clinician to answer that. So I'm going to ask Upasana, please, too.
So thanks for that question. My name's Upasana. I'm a consultant geriatrician and I work at East Kent Hospitals, which means I specialise in looking after older people, but I also see a wide range of people who have very rare conditions, neurological conditions, that is. And the reason I appreciate your question is because there's never been more awareness that within a wide population we have lots of diversity, and within that we're going to have conditions that present very commonly and other conditions that are very rare. There has been an awakening, I think, over the last 2 years in the clinical forum that we've got to be working as specialists in a networked arrangement. So I collaborate quite closely with Gillian Evans, who is a blood disorder consultant, around patients who have rare conditions like yours. And we've got to be using this opportunity as clinicians, I think, to increase that awareness and to spread that network so that it's looking at the whole patient's pathway, whether you're at home or in your general practice or in a general hospital or in a specialist hospital. So I think that whilst we're doing some of it already, we've got to use this opportunity to do a lot more of it, and definitely in a wider context. I hope that answers your question somewhat.
So under the new arrangements, if I've understood what you've said, there'll be more opportunities to spread the specialist knowledge that has been...
Yeah, so basically what we're going to try to do is, and what we've been doing some of already, is there will be pockets of patients who require absolutely highly specialised care. However, in order to ensure that the knowledge around those specific conditions is well known, we're going to work as networks. So you might have a blood disorder consultant being able to network virtually with Dr. Gupta in his practice.
I understand, thank you. To answer your question, sir. Okay, we might want to come back. I'm going to move on because I know a lot of people in the room want to hear about the hospital options, so I'm going to ask Caroline to come up to the front and just give us a quick overview before we get into the detail. Thank you.
Thank you very much. It's really important to understand the change that we're making in out-of-hospital services, because that does affect what it is we're required to do in hospital services. And, you know, as we said earlier, if there are things which are very common and can easily be provided in out-of-hospital settings, why wouldn't we do that? But that also makes it easier to run the hospital end when you do need to go into the acute sector. So what I'm going to do now is, in the next slide, I'm just going to describe very briefly at a high level what the two options are, and then I'm going to pass over to colleagues in the acute trust who are going to take us through those in an enormous amount of detail. But I think it's something helpful for us just to say what those things are first. So there are two options, as I'm sure you've seen before, and of those two options there are some things that are, in both options we would have a major emergency centre with all the specialist services, just as we were describing earlier. And in option one, that specialist centre would be at William Harvey, and in option two, that would be in Canterbury. The other key thing is that in both of these options, what you will see is that there is a big requirement for us to invest in buildings. And both options require very large amounts of money for us to invest in those buildings. And we will need to, we've done a certain amount of work so far in looking at whether options are financially viable, but in order to go out to consultation, we have to do very, very detailed work. We have to go back to a clinical senate and look at all the clinical model and check that they're still content that that's robust. And we have to do a very, very detailed financial analysis on both of the options. And that's something that we're required to do before going out to consultation, because we can't consult on something which isn't going to be affordable. Now, before I just pass over to colleagues to go through this in more detail, thank you for those who handed these out. And I'm just going to use that as an opportunity to answer the question, why not 3 A&Es? That was one of the options, and the reason that didn't make it through to this medium list is because in an option which has got 3 A&Es, and we don't have 3 at the moment, we have 2, in an option with 3 A&Es, we can't meet all the clinical standards, and therefore you wouldn't be in a position where we would get that clinical sign-off. You wouldn't have the volume that you need for the more specialist conditions in order for us to meet those national guidelines. We are struggling. We would struggle to have a workforce that would enable us to deliver on those 3 sites, and we're already finding some challenges with that already. So it wasn't that option wasn't considered. I'm sure some of you will want to raise that, and we will listen to what it is you've got to say, but just as you've given that out, that is the reason why it was one of the options and why it dropped out. So what I'm going to do now is I'm going to pass over to our colleagues in the acute sector, and we're going to take you through in more detail, because that's one of the things that you asked us to do at the previous events, tell you in more detail exactly what the difference between those options are and what do they mean for people living in this area.
Okay, thank you, Caroline. And while Matt's coming up, it's Matt, isn't it? I just want to use this opportunity to empower you. I have noticed, and I should have said this at the beginning, that some of the speakers are using quite a lot of acronyms and jargon, MDTs, and in fairness, that particular concept has been explained, but urgent care, emergency care, all of this stuff. What's the difference? So my first point is, please feel free to raise your hand and ask us to explain any jargon that we use. I have asked the speakers not to use jargon, but inevitably they fall into bad habits. So please feel free to challenge them on that one. Secondly, whilst we're on the subject, urgent and emergency care, 2 concepts that I've heard discussed already this morning. What is the difference? Does anybody want to help me on that one? Who wants to help me on the difference between urgent and emergency care, please? Yes. Say who you are.
Hello, my name is Jo Jowers. I'm here as a member of the public. I'm also a trustee of something called the Central Ashford Community Forum, which is kind of like a parish council but not elected. Okay. So I was listening to this, and actually the urgent care centre question was one of the ones I had my hand up for just now. Okay. Urgent care, having looked through this booklet, means GP-led services at a hospital.
Okay.
If I've understood that correctly, that would be great to have that clarified. The other question I had, which is linked to this definitions point, was around definition of local.
Okay. Okay, let's pick up both of those points now before we move on, Matt. Excuse me for just interrupting you. So, can I just have some confirmation of the definition between urgent and emergency care, please? Is that proposition, as just described, the right one that we are currently using? Who's helping me on that? Yes, Upasna, is that right?
It's me again, sorry. So I think that we could maybe expand on that definition, that difference between urgent and emergency care. And in simple terms, and without using any acronyms, emergency care would refer to care that's delivered to save lives, care that's delivered in a life-threatening condition, whereas urgent care points towards treatments that may be delivered from minor injury and minor illness. So it's more around the severity of care for me as a doctor than it is about where the place is, where the care's delivered.
So I'm likely, not exclusively, but I'm likely to get emergency care probably from a blue light in an ambulance, and non-emergency urgent care in other settings differently, yeah? Does that make sense? I'm looking to Liz as well. Yeah, okay, good. So that's our answer to the definition one. What about local care? What are we describing as local care? Caroline, can you help me on that one?
Okay, so local care are those things that currently you go to see your general practitioner about. So you would normally go, but you might go and see a pharmacist. And in fact, increasingly, there are other supports that are provided, for example, from the community services or indeed from our colleagues in the councils. So these are the kind of things that you tend to go to your local GP surgery or your local hub for, or is provided by in your local community.
So it's care that isn't provided in a hospital setting?
Yes.
Cool, thank you. Right, sorry Matt, over to you.
That's all right. Good. Okay, so my name's Matt Jones. I introduced myself earlier. I'm a consultant anaesthetist in East Kent Hospitals, and I've been doing a lot of work with lots of healthcare partners over a number of years now to really try and get involved as much as I can as a clinician in this process to make sure that it's it's got some clinical input and really something I believe in. So I'm just going to talk you through a couple of slides just to outline some of the ideas that we are arrived at so far in relation to our hospitals. So how hospitals used to be. Back in the day when the NHS started 70 years ago, we had our anniversary this year. This might look familiar, from pictures of old. This isn't how our hospitals run now. Okay? Unfortunately, many of our hospitals were built for this, to deliver healthcare like this. Okay? And the systems and processes in those hospitals are born out of this type of environment. Okay? I was talking to my granddad the other day. He's very old now, and back in the day he had a hernia repair. And he told me he spent 6 weeks in hospital after his hernia. 6 weeks. We do it as a day case now. Okay, so there's just a very small example and I could go on and on. It's obvious. I think you can safely say we try and do as much as we can, as quickly as we can, as safely as we can. But we need to look at how we're going to carry on doing that, how that process is going to evolve in the future, and that's what this piece of work's all about. What we need to do is look at how we deliver all of our kind of hospital-based services. What you'll see coming out is this idea of networks. We've talked about, Naveen, my colleague Dr. Gupta has already talked about working collaboratively with other GPs. Bigger is better. Okay, working together as teams in networks has been proven to be a better way and is the future of how we should be delivering healthcare. To just give you some examples of what that means. So you might be very familiar with the trauma network work that was started 5-7 years ago. This is a very clear example of a network process where we have a major trauma centre in Kings. The trauma centre in Kings can deal with everything from neurosurgery, cardiothoracic surgery, any kind of major accident you have and you go to Kings. Even if it means driving past your local GP, driving past your local care centre, driving past a cottage hospital, driving past a small hospital, driving past a large hospital, the ambulance will keep going because we know that if they get to if the injuries are such that they need to be in a major trauma centre, they go to a major trauma centre. That's a very simplistic way of describing it, but it's a very clear example of how these networks work. And we are very keen to look at taking that kind of model of healthcare and developing that further as we go forward with this process, using this networked approach. So what is the vision for our future hospital care? As we've been saying already, best, most effective hospital care for patients when they need it. Okay, in order to provide us, to provide patients with the best care we can, to give them the best experience. Using our hospitals differently in the future to improve standards. I've just alluded to the fact that about this networking approach. We can't provide everything everywhere. We've not been able to do that in the past, and we're not going to be able to do that in the future. What we need to do is make sure we've got the right services in the right place for the right clinical need for the patient, so that that patient can get the best possible care. Okay, I'll give you another example. When I started in healthcare as a little junior doctor, there were 2 surgeons in the hospital I was in, and those 2 surgeons did every operation that came through the door. And we used to lose patients, I use that term very loosely, or patients didn't do very well, because those surgeons 20, 30 years ago did the best they could, but they were operating on everything. Okay? Nowadays, we have specialist surgeons for specialist types of operation. And that process will continue because the outcomes are better. The experience for the patient is better. They are experts in a certain area. I'll even give you another example. Nowadays, in urology, which is the urology surgeons who operate on the kidneys and the bladder and so on, and the prostate, they're even specialising. So I've now got urology surgeons who do just kidneys, urology surgeons who just do bladders and so on. I'm sure there'll come a day when we just have a right kidney surgeon and a left kidney surgeon, but we'll see how that goes. So the key thing, the message I'm trying to get across is that we will have 3 vibrant hospitals in East Kent. There is no doubt about that. We've got 3 fantastic sites at the moment. I work across all of those sites, and I will continue to do that. What we need to do is ensure that those 3 sites will be able to deliver a vibrant, they will be different, and they will deliver different services. Okay? But we will make sure that we do the best we can for patients. So how do we want to use this model to improve care? We talked already about moving more care closer to home. Dr. Gupta has already alluded to that, and we are very proud in this process. For the first time, we are working very closely as an entire health economy. The amount of meetings I've had and my consultant colleagues have had with GPs in the last couple of years is fantastic. We never used to do that. It used to be them and us. It used to be out there, and it used to be us here in hospital. That's gone. Okay, this is where the networked approach carries on through into the whole health economy. So if a GP sees you and not sure if we can get systems and processes in place that mean you don't have to come to hospital in the first place, that's got to be a good thing. You can tap into a specialist, an expert, a right kidney doctor who knows everything there is to know about your right kidney. So when you've got a problem with your right kidney, you can deal with it. Routine hospitals, hospital care remains local. That's another key thing. We cannot provide everything everywhere, as I said before, but what we want to do is try and provide as much routine care as close to people as they can, and that means replicating that as best we can, based on the models that we need to do, based on the urgency, or as a partner, my colleague there was saying, about the clinical severity of the conditions. Okay, so it's got to match the clinical severity. Certain specialist hospital services should be located in one hospital to improve your care and recovery. I think we've got that message across, okay? If you need a very complex operation with a specialist surgeon, there's a team of 4 of them. They've got a team of specialist nurses. They've got a team of specialist therapists. There's a specialist intensive care unit there, a specialist theatre, a specialist piece of equipment. So whether it's facilities, staff, equipment, personnel, the services we deliver, if we want to do a really good job for that, for you, for that patient, for that condition, we do need to locate those things into one hospital, because we can't replicate that over and over again. Just a final message there, this is another nationally recognised thing. If we can separate out our planned operations and move them away from the complex emergency pathways, we tend to find it's easier to manage those flows and those patients, because there's not a conflict in terms of resources. Coming back to the slide we saw earlier, so of the 10%, most of your hospital care is delivered, most of your care is delivered outside hospital, but the small proportion that is delivered in hospital, of that, most of it is routine in terms of outpatients, in terms of day surgery. And we in the East Kent hospitals, we do 87% of all our surgery operations you have are done as day cases now. So most of this sort of stuff can happen in this kind of environment, right? So when we're talking about specialist centres, major emergencies and complex medical care, we're only talking about, in terms of the whole health need, a very, very small number of people, which is good. So, just to reiterate again what I was saying about services need to be together. To improve care, we do need to put some services together. And those are the kind of services we can't replicate because of the complexity of the care that's required, or the number of patients that it's going to deal with. So I've put some examples up there. I think I've talked about sort of major accidents and things. I've talked about heart attacks. Again, there's a good example. You know, 30 years ago when I started, if you had a heart attack, we'd give you an aspirin, we'd tuck you up in a bed on a long Nightingale ward, and then sort of just pat your forehead and hope, let your heart recover by itself. Those days are gone. We've got specialist interventional teams. We've got a very, very well-structured way of managing heart attacks now, but it does require lots of support from a whole team approach. A couple of other examples there. Obviously, you've got at the other end of life down here, obstetrics, midwives, neonatologists for complex childbirth and children. Having an operation as a child is a very specialist thing, and it requires specialist teams, specialist equipment, specialist environment. It would be great if we could have, a hospital or an area where children are operated on that's just set up for children. That's all, the environment, the staff, what people wear and so on. What I'm talking about is locating that together for the benefit of the patient. Okay. So I'm going to stop there. I thought Liz was standing up, so I'm going to hand over to my colleague to go through the next slide.
Liz, just before you start, Matt has highlighted children's surgery and paediatrics and midwifery. And I think, have we got any specialist nurses in the room that deal with that stuff? We have. We've got 4. Fabulous. I just wonder, what's your comment on this? Do you agree with the sort of general approach in terms of because obviously we've talked about frailty and end of life and geriatric stuff. What about early side?
So good morning everybody, my name is Ursula and I'm Head of Midwifery and Gynaecology at East Kent. So I think what's really, really important is, and I've been a practicing midwife for over 25 years. I've seen women in a very uncomplicated pregnancy, birth, and the appropriate birth setting for that particular lady and what she chooses. But equally, I've seen some ladies go through pregnancy and delivery that have very complex childbirth and delivery. And what's very, very important is that we have the right specialties available in a timely response for those particular ladies. Now, for anybody who wants some reading, the State of Maternity Services report that was published in September this year actually highlighted that women are having their children a lot older, so they're over 35 years of age, because of course, the climate that we're in at the moment, and that often comes with additional complexities, some medical conditions, I'm sure you all know, such as diabetes is on the rise, and that presents complications for the mother in pregnancy and delivery, but also for the newborn baby as well. So it's really, really important that the woman has the right choices, but equally that from the beginning the right birth planning and the right specialists are in place.
So this model, Ursula, would support that proposition, would it?
It would support, and what's very important is that we make sure that we cover all of the options. So we do have women who have home births because they have uncomplicated pregnancies, and it's really important that from the outset that conversation is held and we have good personalised planning of a woman through her pregnancy and birth.
Okay, thank you. Okay, some more detail about the options then, Liz, please.
Oh, do you want? I was just going to say.
Can I ask a question about that, particularly about the maternity services? Sorry. Hello, my name's Maria Pizzi. I have a particular interest in this because my daughter just gave birth 5 weeks ago. Obstetrics. Complications in childbirth are unforeseen. You cannot predict them. So where you can have an uncomplicated pregnancy, you don't know whether that's going to turn into emergency during the delivery. 5% of births can result in hemorrhage, which happened to my daughter. Luckily, she was at William Harvey. She was in a consultant-led unit. Crash team came in and saved her life. Had she been in a midwife-led unit, possibly some 40 miles away from the nearest consultant-led unit, we may not be in a position of still having our daughter. The Birth Trauma Association report found that 1/4 of women were transferred during delivery from midwife-led centres to consultant-led wards during their actual labour. Maureen Treadwell, the co-founder of the Birth Trauma Association, says, even when someone is deemed low risk, something can still go catastrophically wrong. Midwife units are being recommended, but there simply isn't the data to support that recommendation to first-time mothers. We're not saying that they're not safe, just that we cannot say for certain that they are. This proposal would centralise consultant-led maternity care to one centre in the whole of East Kent. And I'd like everybody here to consider that in this proposal. I haven't heard very much that would support that, how care in the community or local care or anything else would actually deal with a catastrophic incident during delivery, and how people are going to be transferred, blue lighted. I mean, unless ambulances are sitting outside maternity-led units waiting to go, you'd have to wait for the ambulance to get there, and then there will be the travelling time.
So, thank you very much for that question, Ursula. I know you'll want to answer that. I wonder if I just run through the options, because there's two different options that have two different solutions around maternity services, and I think it'd probably be useful to understand the two options, but maybe we can go back to Maria's point as the first question when we're answering questions.
Thank you.
So, good morning, and thank you again. I'm Liz Shuttler, I'm the Deputy Chief Exec of East Kent Hospitals, and I'm just going to spend a little bit of time running through the options so that you understand what we are proposing. There are two elements of the options that are exactly the same, and that is this top element, the urgent care for illness and injury that we clarified in terms of your point. We are looking to offer that on all of the hospital sites, and so you would still be able to access that in all of the options. Then, as Matt has talked about, the specialist services that we offer, we are looking to put all of those specialist services onto one single site that is co-located with an A&E. Now, Matt ran through a number of examples, paediatric surgery, about why that's good, and the road traffic accident for me is one that is really important. Of course, if you have a major road traffic accident in any of these options, you would be flown straight to King's because of all the specialties that they have there. But actually, if you have a road traffic accident locally and you could be taken to our local trauma centre, it's really important that you access locally some of the specialties that we've got. And so at the moment, we have a trauma unit at the William Harvey. We have, as you saw on the video earlier, head and neck surgery at the William Harvey. Nick Goodyear talked to you a little bit about his specialism. But vascular surgery, the surgery that deals with vessels, is at Kent and Canterbury. And so what we are trying to do is put all the specialties that you might need together onto one site so you can access that. And that is consistent in both of the options. So when you need that really specialist care, you get it immediately. Another good example, which hasn't been highlighted, we talked about urology, and the robot that was pictured in one of the slides, I think, that Navin talked about. That robot provides care at Kent and Canterbury Hospital. It works predominantly on urological cases, so prostate cancer, that kind of thing. Absolutely fantastic local service, has reduced the lengths of stay for patients really significantly, and has improved outcomes for patients significantly. But actually, if we put that on another site where a number of other specialties are, other people could benefit from that, because at the moment at Kent and Canterbury, we don't have inpatient complex gynecology women's surgery. But actually, if that robot was on a site where we were doing that, those patients could also benefit. So there's some really good examples of why we're looking to put those specialist services together. So in option one, for day surgery and outpatient care, all hospitals would still offer that. That's that 86% of care that Matt talked about, so 9 times out of 10, that is the type of care you are going to our hospitals for, and you would continue in option one to go for that locally. In option two, 9 times out of 10, you would continue to go for day surgery and outpatient care to Queen Elizabeth Hospital, Queen Mother at Margate, and William Harvey Hospital. It's when you get to the complex end of this, and so complex inpatient care, which is a very small percentage of what we do. In option one, as now, you would continue to receive that at Queen Elizabeth, Queen Mother, and the William Harvey, but in option 2, that would be centralised into Kent and Canterbury. And then finally, for that emergency, that life-threatening care where you needed to access specialties and specialist teams, in option 1, that would continue to be provided at QE and the William Harvey, but in option 2, that would be moved to Kent and Canterbury. So I'm just going to run through what does that mean if the William Harvey is your local hospital. I'm presuming for most of the people in the room, William Harvey will be your local hospital, although for elements of the Ashford Borough Council, I think possibly some people might live closer to K&C. In your packs, you have these slides repeated for all 3 of the local hospitals, so you can have a look at what it means for local people in different areas. But just to reinforce what everybody's been talking about today at the top here, 90% of what you access in terms of NHS health services will still be available in Ashford. In option 1, you would get your emergency and life-threatening treatment at the William Harvey. You would go straight there. The specialist conditions, so we would bring inpatient kidney treatment here, we would bring vascular surgery here, and patients from the entirety of East Kent would access those services. Emergency and complex planned care would be here at the William Harvey, and children's inpatient care and maternity consultant-led services and midwifery-led services would still be available here. And day surgery, routine surgery, chemotherapy, kidney dialysis, all of those routine appointments, tests, scans that you go, they would all be available locally. You would move to Kent and Canterbury for routine inpatient surgery, and so we've given some examples around hip and knee replacement, and Matt touched on that. Last year, over the winter, because our A&Es and our beds were so full of elderly, frail people, we stopped operating on patients and on trauma orthopaedic patients for a 3-month period. That meant the numbers of patients that are on our waiting list rose dramatically, and particularly the number of patients that have been on the waiting list for over a year, waiting in pain for an important operation, rose dramatically. If you move that routine inpatient surgery away from the A&E site, where large numbers of patients are coming in through the winter, you can protect and ring-fence those beds, and you can operate on patients all year. And so the plan would be to do that for hip and knee replacements, and potentially for some other inpatient routine surgery at the Kent and Canterbury site. In all of the options, the cancer centre, radiotherapy treatments would continue to be offered at Kent and Canterbury, so if you were going for those as now, you would continue to go there. You would go for some routine appointments, tests and scans to Kent and Canterbury. We have a large outpatient facility there, and often people are booked there. And there's an ongoing recovery and rehabilitation unit overnight, so that's option 1. So then if we turn to option 2, exactly the same as the first option, 90% of your healthcare needs will still be available in Ashford. At William Harvey, that 86% that Matt talked about, 9 out of 10 patients would still come to the William Harvey for your care. You will be offered urgent care for minor illness and minor injuries. Your routine planned elective inpatient care would be locally, off the major emergency A&E. Day surgery, day treatments would all be available locally. Routine outpatient appointments, children's care, maternity day care, all available locally. There is a question about whether we would want to provide midwifery-led units. I think Maria articulated some of the questions that we would have to ask about whether we would want to do them, how many we would want to do, and how they would work. There are parts of the country, there are parts of Kent where those run, so Bateson Hospital has a midwifery-led unit, but that's part of the process. And part of the thing that we want to hear from you today, we would like your views about that. Do you think midwifery-led units are important, and should we offer those? But in option 2, for your emergency life-threatening treatment for those specialist conditions, you would need to travel to Kent and Canterbury. And for the complex inpatient services that support those, children's inpatient care and maternity, similarly, there would be a travel to Canterbury. So, what does that mean? What we're trying to do is ensure that you only come to a hospital when you need to, and when you come to a hospital, you go to the best place. You go to the place where you access specialist care when it's needed, but that's not always going to be your local hospital. Sometimes you will have to travel, and the options have different travel times for different parts of East Kent. We want you to be treated sooner, so we want you to have shorter waits for your treatment, and actually if we can implement some of those separations, some of those specialist networks that Matt talked about, we can deliver that. We want you to spend less time in hospital so you can be treated by a specialist team, and we want you to get home sooner.
Okay, thank you, Liz. I'm sensing that people probably need a break and a cup of tea, but before we do that, whilst it's still fresh in your heads, have you got any questions on what you've just heard from Matt and or Liz? And I'm going to go to this gentleman here who hasn't spoken yet, please. I will try and get round, I promise.
Hello, Mike Hanson, I'm just an ordinary appointee. I mean, the argument for concentrating specialist services seems to me overwhelming, but what's the basic rationale for choosing Canterbury? Is it to do with geography, or is it opportunistic?
So the one thing I'd say is that I don't think we have chosen Canterbury yet, have we?
That was my first point. We've got 2 options. One of those options would centralise those services at the William Harvey, and the second would centralise those services at Kent and Canterbury. There is an element of opportunistic around that option, because we have been approached by a local developer who wants to build some houses, and as part of that build a shell of a hospital for us, and so there's a reduction in capital costs, which meant that there was an opportunity for us to look at that option.
Okay. Anybody want to add to that? Yeah, I can see people behind me. I was going to go here first, please. Julie, have you got a mic? Can you grab another mic from Martin?
You mentioned specialist care, and 90% is what you're looking for to get specialist care on any given illness. Children with matters of the mind, they're not getting 90% of specialist care. As mind itself will tell you, there's this backlog of getting treatment, backlog of getting a test, no beds in counties. So why would you use this terminology 90% when there's definitely, as you've mentioned here, mental health, you've mentioned children, better services for children. Yes. And we are talking maybe in Kent 200,000 children that have a mental health problem. Well, matters of the mind would be more appropriate word.
So the percentages I was talking about were acute hospital services, just talking about those services. If I can hand on to Helen to talk to you about mental health services, that would be helpful.
Thank you. Yeah, it's a national scandal, isn't it, that children can't access mental health care when they need it. Completely agree. That's been recognised by central government, thank goodness. We've now had in the budget recognition that extra funding for mental health is required. That's good news. But I completely agree, we need to give that attention. It is a separate issue from this, as Liz said, we're talking about acute general hospital beds here. You're right, we don't have any child and adolescent mental health beds in the county. I really wish we did, and I would love to be commissioned to provide them.
Okay, let's just deal. It's Maria, isn't it?
Yes. Sorry to be rude, but the last time the government injected money into mental health, it was used for other services.
I would welcome a conversation about it. I don't think that it was, because it was all very clearly earmarked. The bigger argument is about whether the amount identified at central government flows effectively straight through to the front line, and there have been discussions about that. But the good news is, for the first time ever, and I've worked in mental health for 35 years now, for the first time ever, clinical commissioning groups are required by the government to publish the amount they're spending on mental health, and that's what's helping us make sure we get the right money to the right place. But I completely agree, there's more to do.
Okay, let's pick up Maria's point, because I'm aware that it remains unanswered. So Lisa, please.
And thank you, Maria. A very distressing time, I'm sure, not just for your daughter, of course, but actually this demonstrates the impact it has on the family as well. So it's very important that the appropriate recovery is in there. We talked about it's not just physical, but it's psychological as well. So what's really important is what you have raised is that we look at and listen. That's very important. Listening to some specific maternity groups as well, and also what it is that you would like from the services. So we talk about midwifery-led birth centres, but actually, do the women want that? And that's what's really, really important. We can look at lots of different evidence that's out there. We can look at the Maidstone model up the road. It's been open 7 years now with good outcomes, benchmarked against the birthplace study. So that's really important for us to take on board what you're saying, take on board individual experiences. I do have to say, in my 25 years as practicing as a midwife, that we will get the unexpected. What's really important is that as a team, we are ready for that unexpected. You demonstrated how quickly the response was for your daughter, and I'm very pleased that that happened and proud of our specialists.
Okay.
Can I
hope that answers your question.
yeah, if I can just come back.
Yes, of course you can.
Yeah, what my daughter Laura received was excellent care, but that's because she was actually in a consultant-led unit and it had all the facilities to provide that. When you're talking about choice, in most most midwife-led maternity units, there is not the choice to have the kind of interventions that women may require or may need, and I'm talking about pain relief particularly. I do understand that a lot of women choose not to have their child in an obstetrics unit because they don't want all of that interference. And I think what can be done is there can be a discussion about how we can provide obstetric units for everybody with a choice of the care they have. So birthing pools, etc., provided in all of those units, as opposed to women have to make the choice between being in much more dangerous circumstances because they don't necessarily want all the intervention.
So, again, thank you. And choice is a very important word, but what's also very important is the personalised planning of that individual lady. I will just say that we do have co-located midwifery-led units on both of our sites, so they're near our obstetric labour wards. They work very well, and nationally most units have got co-located midwifery-led units, so you've got your birthing pools, and again it's the elements of choice. But within the model, we are including co-located within that centralised model, so again trying to meet that choice agenda for women.
So Ursula and Maria, can I make a suggestion? After the break we are going to just try and have some more individual table discussions. I know you and some colleagues here are particularly up for having those sort of crunchy discussions with people who've experienced it. So can I make a suggestion that after the break, perhaps you form a table and have a more detailed discussion with Maria and anybody else who wants to talk about that particular issue? Is that? Thank you. Very good. So, yes, sir.
Hi, my name is Mark Piddock.
Hi, Mark.
I'm coming here from a position of ignorance and hoping to get educated with an open mind. One question that hasn't been answered is there's good material on the tables. It talked about 17 options reducing down to 2, and we talked about 2. And you briefly touched on not having an A&E in a third site. And some reasons were given, but they weren't given with much substance behind them. I'm sure that, given the body of education that's in here about this subject, it's the right call to narrow down, but I would quite like to understand the logic behind getting to that.
Okay, good challenge. I'm going to ask Liz to address that one, please.
Well, I'll kick it off and then maybe Matt, you can have a... So I think it's important to realise when you think about an A&E is not just the front bit of a hospital. To run an A&E means that 24 hours a day, 7 days a week, you have to be ready to accept any child, any woman, any old person with any complex disease. And so you need a whole set of services that back that up. Now, Matt's an ITU consultant, so you need ITU. You need the general surgeons that Matt talked about because you might have to have an operation. You need the gynecologists, you need the paediatricians. And our ability to be able to provide that A&E in 3 places with all of those backup services just wasn't possible. And we stopped doing that in 2005. And so we consulted and set up 2 A&Es, one at QE and one at the William Harvey, and we haven't had 3 A&Es from that period. So we did look at 3 A&Es because we had been challenged on it. And again, because of the specialist teams that you need, we couldn't recruit to that number of specialties on all of those 3 sites. We have about 120,000 major attendances a year. If you split that over 3 sites, they are tiny, tiny numbers of patients that are going to those sites. So I don't know if I've either blown.
No, I was just going to say, I think you've answered the question. It's all about getting the right people to the patient, and in order for us to run robust rotas and have that whole team approach of specialist staff, we just can't do that over and over and over again. You could say 3, 4, 5, 6, 2, 1. At the end of the day, what we've got to do is look at the volume of work, the number of patients we get, which we do in great detail, looking at the population, looking at, in fact, projecting that as well. That's an important thing to remember, that we're not just designing a service for tomorrow, we've got to make sure that it's fit for purpose for 20 years, 30 years' time. What are people going to get ill with? Where are they going to live? What are they going to present with? And what's the best way to deal with them when they have a critical emergency? And which staff, and which equipment, which facilities do we have on hand to deal with that, to ensure that you have the best possible outcome? And to do that involves the degree of co-location.
How have they done in terms of answering your question? I'm getting a thumbs up, brilliant, great. Yes sir, hello.
My name's Paul Clokey. I'm at home and crippled with pain. It's 12 o'clock at night, family have all had a drink. They don't know where to go. What do they do? Because are you going to increase the number of ambulances? Because if you're going to move everybody from Tenterton and Rolvenden, for instance, all the way out to Canterbury, it's an hour's drive. People in the house can't drive. So are you going to increase the number of ambulances by a large number?
Okay.
You're an hour away.
Okay. So every time we look at moving hospital services, we involve the Ambulance Trust, and they look at the travel times between different locations, and they can work out how many additional ambulances they would need to make sure that they continue to achieve the targets that are set. They're obviously on an improvement journey, and we will be working with them as part of the analysis of these options to understand what the additional ambulances are that are required for both of the options.
Can I turn it the other way around? Just ask, are you saying the household...
Let me just give you the mic, yes.
The question the other way around is, are you asking the household to decide whether it's a Canterbury call or a doctor call or what? So who's... Because at the moment, obviously, if the ambulance arrives, it's perfectly well which hospital to go to. But the average householder doesn't know. And
that's a good question.
Yeah.
So that's
If you ring an ambulance now, ring an ambulance in the future. It's up to us as the professionals and the organisations that run health services in East Kent to make you and get you to the right place. We're not asking you to make those decisions. So if you ring an ambulance, continue to ring an ambulance.
Okay.
If you ring your GP, ring your GP.
Listen, I've got Navin here. Dr. Gupta wants to add.
I would probably answer the question slightly from a community point of view. And I think the question will be about what is causing that pain and that distress. So it's about going upstream, having the primary care, your GP and the team to have a clear care plan in place for that particular person. Therefore, at 12 o'clock at night, when you call someone, whether it's an ambulance person or it's an out-of-hour GPs, that person has got that care plan in place to deliver the care, most possibly, hopefully at home. And obviously, if that is not possible, then consider the next step. So I think the first step needs to be, can it be done more locally, which is possibly at home with a clear care plan in place? That would be my probably the first answer.
Okay. Thank you. Lady here's been waiting for a microphone.
Thank you. Now we're on the subject of transport. I've got some points to add. As a fairly new resident in Ashford and also as a dementia carer, I really think you need to coordinate with the transport planners of Ashford. Several examples. For example, if my husband gets appointments at Eureka, there was 1 month when there wasn't a bus that could take us there because there was a hiatus and the bus service had just cancelled the e-bus. So that's a problem. You're throwing onto some of us pensioners the cost of getting around the system. Another example, admitted emergency care, waiting in A&E for 8 hours. By the time I emerged after he'd been taken into the ward, it was 9:30 at night and I was waiting for a bus outside William Henry. Right, well, I tried ringing the taxis. I only got through the 3rd time. You know, these are the realities of looking at transport. Another example, trying to get to the dermatology hospital, the centre is in Canterbury. There isn't a bus directly from the station, and if you're a bit infirm, it would be wonderful if there was at least a little bus that takes you directly from the train station to the hospital. So I think you need some transport planners as well to help you with this planning.
I'm seeing lots of nods around the room, so I think it's a point well made. Can we have a commitment to consider that as we move forward, please? Yep. Yeah, absolutely. Yes, Caroline, thank you. Okay, looking for people who haven't spoken, and then I'm going to take 2 more before we break. Behind you, Linda, please.
Can I ask that we have a meeting like this in Tenterden? Tenterden district will have the longest journey under the Canterbury plan. There's a very elderly population and there's a rising population. Huge numbers of houses are being built in the area. People are very worried. And yet we are not scheduled to have a meeting at all. As somebody's already said, public transport from Tenterden has been cut. So we'd really appreciate it if you could have a meeting like this for us in that area. Thank you.
Okay, thank you. We'll look into that. Thank you. I'm looking for one more who hasn't spoken. Did I see an arm back here somewhere? I saw an arm there. You haven't spoken, have you, sir?
Good morning. My name is Brian Cumming. I'm from Ashford. I have a connection with the ambulance service, so I was very keen to, and I hope that the consultation with the ambulance service is really intense, because it's very important that sort of travelling time, and I think that affects almost everybody. The one thing I would ask is on option 2. Obviously, this the rebuild is something that seems to be standing out, and I would ask that if this is an option to build a new hospital. Does it have to be an A&E consultant-led hospital? What's the difference between building using this option just to create a new modern hospital on perhaps on a slightly better access site?
I thought you were going one way, so I'll start how I was going to start, and if I don't get to the end, pull me back. The developer was very clear around the option that he wanted to support and the site that he wanted to support. The actual shell of the hospital isn't big enough for everything that we want to put in it, and so we have to utilise the rest of the Canterbury site as well to make sure that we can fit those patients in.
So
because
it wouldn't be a move away completely from the site.
So because when you look at the percentages, the number of people, it's just over 1% of people going to this hospital, but actually the facilities they use are really expensive, the diagnostics, the beds, they're really expensive to build, and so that's why it limits it to that site and that option. Did I get there? Yeah.
Okay, and just to reinforce the point that I think I've understood, is that this is all still work in progress, and you're still going to have to do some detailed work around all of these.
Absolutely.
Okay, I'm now going to move to a break, please. Is this really urgent, Marie?
It is.
Okay.
And it's general, it's not just about maternity
Okay,
services.
well, I will indulge you then for...
Thank you.
Make it quick, please, 'cause I think people need a break.
Okay, so there is currently no evidence that the proposals to centralise these kind of services, emergency services, will improve patient outcomes. We'll hear a lot about centres of excellence because that's come from NHS England, and that's the language that's being used. There is evidence of higher mortality rate connected to travelling time. For people in the room that probably haven't been connected with any campaigning, this has been presented to you as clinician-led. It's actually political and ideological led. It's come from Simon Stevens, CEO of NHS England, who was appointed to run the NHS in 2014. The proposals that he's putting forward for the 5-year forward view have not had any mandate. Nobody's had any votes on this at all. It's been carried out. Simon Stevens was appointed from, let me get this right, a health insurance company in America, United Health. He was the CEO, pushing the American system. And if we carry along these routes and we don't actually fight back, that's where we're going. Centralising of the expensive services, and therefore all of those other things that are a bit more lucrative and can be provided by Virgin Care.
Okay. I'm not going to ask anybody to comment on that. I think it's an interesting and different perspective that we want to listen to. I think what you have heard over the course of the morning is a different perspectives from a number of the clinicians in the room that present an alternative view. So I'm going to leave it at that for now, but we can come back to that discussion later on. So.